very lovely meeting in Cairo, which unfortunately I have not been able to attend personally, but I'm happy to send my recording. So I'm going to speak on, do we need to assess hormone levels besides doing ultrasound monitoring during the menstrual cycles. We all know that cycle monitoring in ART is a standard of care and which we have used for the last 60 years in order to get a good number of good quality eggs and to reduce complications such as ovarian hyperstimulation syndrome. The cycle monitoring was routinely done through transvaginal ultrasound and through serum hormones in order to evaluate the response. But as the years have gone by, recently most of the guidelines do not mention about the use of any estrogen levels or progesterone levels during the fresh stimulation, during ovarian stimulation. And if you see this Cochrane review database, which has been done on women who are undergoing ovarian stimulation with gonadal treatments and IVF and HC procedures, where they have compared women who went through ovarian stimulation by only transvaginal ultrasound and compared it with women who have monitoring with ultrasound and TBS and serum estradiol. And they have found that at this point in time that and they had equal number of cases in both the groups, and this database included 6 trials with 780 women, 81 women undergoing either TBS alone or with estrogen monitoring added. And these trials were done way back in 2014, but and since then no further randomized controls have been added. But the evidence found was that it's a very low quality evidence with poor reporting methodology. And the conclusion was that there is no benefit from monitoring with ultrasound plus estrogen versus only uh, versus only ultrasound in relation to both pregnancy rates and hyperstimulation syndrome, and a similar number of eggs have been retrieved, and hence it was found that both methods are safe and reliable. But when two online surveys have been done in 2019 and 2020, it was found that most of the centers, between 15 to 7 out of 17 IVF centers who responded, said that estrogen levels are to be done as a marker of impending hyperstimulation. Ultrasound alone is not enough, and it also helps to indicate when is the right time to use the trigger and to also guide in adjusting the gonadotropin dose. And they also mentioned that they would like to do progesterone levels as an indicator to assist in decision making for embryo transfer prior to doing the embryo transfer. So this is related to cycle monitoring, especially during the stimulation process. And it had shown, the studies have shown, that when the progesterone levels, as you see over here, on the day of the trigger, if the progesterone levels have been found to be, sort of high, if you see that here the progesterone levels are less than 0.4 and here they are over 2 nanograms per ml, as the progesterone levels go on rising, you'll find that the pregnancy rates or the linear cleavage stage embryos will go on reducing the implantation rate with cleavage embryos, and also the implantation rate with day 5 embryos reduces as the progesterone goes on increasing. Similarly, you find that the live birth rate follows a similar pattern. So it's very clear that if you do a progesterone level prior to the transfer, you will find that if the levels are usually higher than 1 nanogram per ml, you will find that the pregnancy rates and the live birth, implantation rates and live birth rates will go on reducing. Now, why does this premature progesterone elevation occur? And it has been shown that because of the extra amount of angiogenesis which is available leading to high estrogen levels, it is shown that there's extra amount of progesterone also being secreted, which can then result in an LH surge, even though a patient may be using any kind of GnRH analogs. And hence, we need to be sure that if we are doing giving the trigger, it is important for us to, sort of do the progesterone levels, which will help us to decide whether that particular cycle is good enough to go ahead. But in such cases, one could do the ovum pickup. We could do and freeze those embryos, create embryos and freeze them, and transfer them in the next cycle when the progesterone levels will not affect the implantation rate or the live birth rate. And therefore, we see that, and there's enough scientific evidence shown that when there's a premature rise in progesterone, there is evidence to show that there will be endometrial advancement on histology. There is a lot of disturbance in the microRNA genes, and there is an aberrant gene expression affecting the implantation window, and therefore there is a decreased endometrial receptivity and increased pregnancy loss. So in short, we have to cancel that cycle. And what is mentioned is that you freeze all the embryos and save them separately to be transferred into a frozen thaw cycle in order to manage this premature progesterone elevation. In the freeze-all approach, you find that there will be increased pregnancy and live birth rates in the FET cycles versus fresh cycles, as we see. Now, in short, when you are having on the day of HCG triggered progesterone being more than 2 nanograms in fresh IVF cycles, you will find that the odds ratio is low and the pregnancy rate is low, whilst in the subsequent FET cycles, you will find that the pregnancy rate goes up to more than almost 47%, which is statistically significant. And hence, if the progesterone is elevated prior to the trigger, it is better to freeze the embryos and save them for a frozen thaw cycle where you get better results. Now, coming to the frozen thaw embryo cycles, which have now become the mainstream due to reproductive development, we find that it's definitely gives you better results because it helps to reduce the hyperstimulation. We also know that we need to freeze them when we want to do any pre-implantation genetic testing, either for aneuploidy or for morphology. We want to prevent this endometrial embryo asynchrony which occurs. We have reliable safety and improved live birth rates. Of course, we also know that with FET cycles, the chances of hypertension in the pregnant woman and large birth weight babies is higher than it is in the fresh cycles. Now, this endometrial preparation can be prepared with different protocols for FET cycles. Whether we are doing a natural cycle, which may be a true natural cycle with no intervention, or we do a modified natural cycle where we are triggering with HCG, or we do the HRT cycle with down regulation with GnRH agonist or without down regulation, or we may do a mild ovarian stimulated cycle either with letrozole or without letrozole. But there is no consensus on which is the best endometrial preparation method, and therefore, every center uses what they are comfortable with. Now, in these frozen cycles, should we measure progesterone levels prior to doing the embryo transfer? And this study was a very good study, which has been reported saying that patients in whom the progesterone was started, and these patients were the one where single euploid FET cycles were being done, where the embryos had been tested for their, euploidy status. And these were the cycles where there's nothing wrong with the embryo. All the cycles were artificial cycles where intramuscular progesterone was used in a dose of 50 to 75 milligram per day for 6 days when the endometrial thickness was more than 7 millimeters, triple layer. And the patients were divided into two groups based on the progesterone levels, which are done on day 3 or 4, and they were evaluated 1 hour before the embryo transfer. In those patients in whom the progesterone levels were more than 20 nanograms per ml on day of the embryo transfer, those were the patients which were associated with low pregnancy rates. So as you see over here, once the level goes above 20, you will find that the missed abortion and miscarriage biochemical pregnancy rates were going up, whilst the live birth rates, which are in the red line, they start going down. So in short, ideally we need to have a level anywhere between 15 to 20 nanograms to get good pregnancy rates, or anything even above 10 is good, but this is a good level to have to get good pregnancy rates. Then when we do the HRT cycles, the monitoring is done during estrogen supplementation, where you assess the endometrium by ultrasound. But if you do the estrogen levels and if you find that the estrogen levels are more than 400 picogram per milliliter, the live birth rate and clinical pregnancy rate may go down. But in another study which was done in 2020, it showed no statistical differences. Similarly, whether to do LH levels or not, there is a conflict between different studies, and here it has been shown that if the LH levels are low before the progesterone administration, it leads to decreased live birth rate. So in short, we are not very sure whether we require to use estrogen levels or LH levels, but definitely in these various types of cycles which we do, in all of them the progesterone is given depending on which protocol we use. We either do the embryo transfer either on day 5 or day 6 of the progesterone, and that is known to give good results. Now, there is a luteal phase support required after doing any of these cycles, and in the natural cycle, which is done with the frozen embryo transfer cycle, which is through a natural in a natural cycle, we find there are different protocols which have been tried. Some of them giving progesterone 6 days later, some of them 3 days later, some of them on the same day. So, in short, there is a difference in opinion in various centers. Some of the centers have used vaginal progesterone, some have used intramuscular plus vaginal, some have used oral plus vaginal. So there's been a various types of progesterone protocols being used. But in what has been shown that we need at least a 10 nanogram per ml progesterone level in the which is normally seen in a mid-luteal phase of a natural cycle, we find that it should be at least that much for secretory transformation of the endometrium. And the lowest progesterone level which has been associated with pregnancy is 10 nanogram per ml. There is sorry for this error here. But different days of progesterone, all these different studies have got different cutoff levels, and therefore it's very difficult to assess which is the best, sort of level to be used. But yes, in natural cycles, it's important to see that the progesterone levels cannot be assessed, but in the frozen cycles, we said that it should be anywhere between 10 to 20 nanograms per ml, which is good. And this is what, again, in HRT cycles, when the patient has already had her embryo transfer done, in those cycles, it has been shown that as the pregnancy advances, the progesterone levels go up further. And if we find that the progesterone levels are low, we can help by stepping up the progesterone dose. And if we find that the levels are too high, we may expect a poorer outcome on the day of embryo transfer. If the progesterone levels are too high, you may not get a good outcome. And hence, doing a progesterone level before embryo transfer is useful. So these patients who have this study which has been done in HRT cycles where euploid blastocyst transfer is done on day 5 or 6, they found that if the progesterone level was more than 20 nanogram on the day of ET, there was a reduction in pregnancy and live birth rates. Now here there's another study which talks about more than 32.5, and therefore you see, if you see different studies, you'll get different rates. And what we must remember is that what is ideal is anywhere between 10 to 20 nanograms per ml. Then we come to the frozen cycles where we are talking about giving any kind of a supplementation prior to the embryo transfer. Would any help can be given in these cases? And here a standard protocol versus a surveillance protocol has been used, where the progesterone levels and estrogen levels have been done prior to the transfer. And in those patients, when they found that the estrogen and the estradiol and progesterone levels were done one day before the frozen embryo transfer, and the estradiol doses were increased if the E2 was less than 150 picogram per ml, and the progesterone dose was increased from 50 to 75 milligram if the level was less than 15 nanograms per ml. And the cycle was cancelled if there was inadequate endometrial thickness or inappropriate estrogen or progesterone levels. So in these cases, in the surveillance protocol, it was found that it was something which was that I'm sorry about this, but in the surveillance protocol, it was found that when the step up was done with the estrogen or with the progesterone, the pregnancy rates were much higher than in the standard protocol, and this is statistically significant. So we must remember that we still require a lot of prospective RCTs to help us understand what really is going to help. But based on the studies which have reported, we must remember that cycle monitoring via ultrasound alone is not enough, and I think we need to use serum-based hormone assays during ART, especially in PCOS women, which is now considered the standard of care. It provides information on ovarian response, assists in optimizing treatment outcomes, and helps in reducing avoiding OHSS. And premature progesterone elevation should be assessed in fresh cycles, and in the freeze-all cycles, we must carry it out if the estrogen levels are more than 3000 picogram per ml. Or more than 16 oocytes are retrieved, we must freeze all the embryos. The serum estradiol and progesterone assays prior to embryo transfer are useful in optimizing pregnancy outcomes in FET cycles. I thank you all for your kind attention and welcome you to visit our website on pcsindia.org. Thank you very much for your kind attention.